My name's Dominic Power. I'm a consultant hand and peripheral nerve surgeon based in Birmingham in the UK, and I'm one of the editors for OrthOracle Hand, Wrist and Peripheral Nerve. This short talk is about cubital tunnel decompression. Cubital tunnel syndrome is a compressive neuropathy affecting the ulnar nerve at the elbow. I believe it's a combination of both compression under Osborn's fascia, but also there's a dynamic element due to tension. So during elbow flexion, the nerve is compressed against the medial epicondylar groove, or may even sublux, resulting in an ulnar neuritis. In my experience, the clinical diagnosis is associated with elbow flexion related alteration of sensation within the ulnar two digits within the hand. It's also associated with nighttime awakening and weakness of power grip due to loss of some motor function within the FDP on the ulnar side of the hand. In the early stages, cubital tunnel is predominantly a sensory phenomena, and like most entrapment neuropathies is associated with intermittent paresthesia. But more severe and prolonged compression can result in numbness that can linger, and it's then in its later stages associated not only with the weakness of the extrinsic digital flexors from the ulnar innervated FDPs, but gradual loss of function and control within the ulnar innervated hand intrinsic muscles. Cubital tunnel is associated with a positive elbow flexion test, a TNL over the nerve at the elbow, and the surgeon should also assess whether or not the ulnar nerve is unstable, whether it subluxes during deep elbow flexion. Neurophysiology can confirm the severity of any compression, slowing of the nerve, both sensory and conduction velocities, loss of amplitude, and denervation within the ulnar innervated muscles. Simple decompression can be performed under a general anaesthetic, a regional anaesthetic, or using a wide-awake local anaesthetic surgery technique. My preferred choice is a regional anaesthetic block at the axillary level, and I supplement this with a subfascial block just at the level of the tourniquet to ensure that the medial cutaneous nerve of the forearm and arm and the intercostobrachial nerve are also covered, as it may not be possible to capture these nerves during a standard axillary block. I release over the surface of the cubital tunnel over the course of the ulnar nerve and look for any cutaneous branches, either the posterior or anterior branches of the medial cutaneous nerve of the forearm, which can cross the surgical site, and these must be protected to prevent iatrogenic injury and the risk of a neuroma. The ulnar nerve is decompressed under Osborn's fascia, and this should continue between the humeral and ulnar heads of the flexor carpi ulnaris to ensure there are no fascial bands causing irritation or compression. Proximally, I extend the incision towards the medial intermuscular septum, but this can be reached with careful retraction, ensuring that the nerve is fully released as it passes from the anterior to posterior compartments of the upper arm. On table, I perform an elbow flexion test to see whether there's any passive subluxation of the nerve, or whether the nerve flattens and is compressed against the posterior aspect of the medial epicondylar groove. If it does, my preferred technique is to perform a medial epicondylectomy, where I take away a piece of bone after releasing and elevating part of the common flexor origin. The common flexor origin is then repaired, and the nerve is allowed to slide into a more anterior position, but it does not sublux, and it now has laxity within it, so it's no longer under tension. I prefer this technique to the often described anterior subcutaneous transposition or submuscular transposition procedures. My experience of these procedures is that these create secondary tether points, particularly where the ulnar nerve crosses the insertion of the medial intermuscular septum into the medial epicondyle, or where the ulnar nerve courses back towards the FCU tethered by the ulnar innervation branch. In all my revision cases, I undertake a medial epicondylectomy, and I consider supplementary Axoguard wrapping, which is a collagen barrier wrap to prevent recurrent scarring. In very severe cases with intrinsic muscle paralysis, I may perform an adjunctive distal ulnar nerve reinnervation of the motor fascicle using the anterior interosseous nerve. So in summary, cubital tunnel is an entrapment neuropathy affecting the ulnar nerve. My primary procedure of choice is a simple decompression with or without a medial epicondylectomy, and I undertake medial epicondylectomy with nerve wrapping in complex revision surgery. Thank you.